All right, so this week we will be talking about allergic rhinitis. You might have known this as hay fever or seasonal allergies, very similar things. Um, but there's a lot to talk about in terms of how it's classified, how we sort of diagnose and treat it. So let's just get right into it. So these are, you can see the things we'll be talking about and some of the learning objectives for today. But I want to go ahead and just sort of define rhinitis, even though we know what it means. It is defined as the inflammation of our nasal mucosal passages, or the nasal mucosa. It can have allergic or non-allergic triggers. So seasonal allergies would be sort of the allergic triggers, and if you have sensitivities to things like the cold or dust mites, that might be more of a non-allergic trigger. This is generally considered to be a pretty chronic disease, and even though it's not often fatal, as with most sort of atopic conditions, the real burden of this disease comes in its sort of quality of life impacts, how it sort of prevents people from being productive at work or at school, how it sort of interferes with just general daily life. You can see an image here that sort of shows how this sinus area, the nasal mucosa, is inflamed, and there's a lot of mucus production as well. So one thing that I don't normally talk about too much in these, but I do want to mention here is just the epidemiology and the distribution of the disease. So it should come to the surprise of no one that allergic rhinitis is really strongly correlated with certain months of the year, so much less prevalence during the winter months, and it starts to sort of increase as spring comes and then really peaks in late summer. And of course that's just going to correlate pretty directly with when pollen is in the air. And another thing I want to sort of mention here is that there's been a pretty significant increase in the incidence of this disease, as there has been with many atopic conditions over the last few decades, particularly in countries like the United States. And I'll get into the reasons for that right now in this next slide. So obviously things like air pollution and urbanization are going to be big factors that sort of cause your immune system to be a little more hypersensitive. And another thing I want to talk about, and this isn't directly related to the United States or anything, but maternal smoking is one of the biggest risk factors for a child developing allergic rhinitis. I'm not entirely sure why that is. From what I could read, I wasn't able to find out a definitive answer. So as far as I know, this is more of just a risk factor or a sort of correlative effect here, but I'm not sure the exact mechanism. But it's interesting to think about because even though it makes sense that air pollution would sort of have that effect, it's interesting that sort of maternal smoking, which is very similar to air pollution, could still sort of preserve that effect in utero. And another really interesting thing I want to bring up, this is very interesting to me, is that you are at a much lower risk for developing atopic conditions in general, but particularly allergic rhinitis if you have more siblings, and especially if those siblings are sort of older than you. And the reason that is this is likely acting as a sort of proxy marker for the amount of viral infections and bacteria that are getting brought into the household. So if you have a lot of siblings and they're all going to daycare, to school, and they're all bringing back these pathogens and infections, this is actually really going to help your immune system at a young stage be polarized towards that Th1 sort of non-allergic phenotype rather than the Th2 allergic phenotype. That's really interesting to think about. Allergic rhinitis is one of many diseases that has these sort of classification schemes that I want to go over, because more and more it's being understood that things are a spectrum, and saying you have allergic rhinitis can mean very different things to two people. So we can think of allergic rhinitis as being broadly classified as allergic, I could say rhinitis can be broadly thought of as being classified as allergic or non-allergic. But within the scope of this, we're going to be really focusing on allergic rhinitis. And this sort of subgroup is phenotyped by its severity and its duration. So you can see here in this image that this is sort of the criteria they use to describe it as either mild or moderate or severe, or intermittent versus persistent. And these would be combined together. So you could have, for example, mild persistent allergic rhinitis. So allergic rhinitis is going to account for around half of the rhinitis cases. I honestly thought it would be a little bit more, but it actually tends to be pretty balanced. And this is going to be, caused by hypersensitivities to airborne allergens. And really the cardinal symptom, the main thing that we're seeing in all of these patients is going to be congestion. So that, what does that actually look like? Well, you can see in this image that the passageways just become a little occluded, either through inflammation or mucus discharge, and this prevents, air from being able to pass through the nasal passages. Another sort of hallmark sign that lets you know that it's actually allergic in nature is that there is evidence of an IgE response to that allergen as well. So, for example, if you notice you have allergic rhinitis during the summer months in a certain area, and you bring those local pollens into a testing center, and you get a sort of wheel and flare reaction upon a skin prick test, well, that would be pretty suggestive that those symptoms are actually allergic in nature. And one thing I want to mention here, this is a very sort of hazy area, but we've talked a lot about atopy or atopic, but there's this emerging concept of entopy or entopic conditions as well. And this refers to IgE that is not systemically distributed, but is only in specifically certain areas such as the nasal tissue. So I just sort of want to drop this here in case you see this term around. Again, this is not something that we will really see in an average clinic. It's more sort of a research item right now, but it's interesting to think that IgE might be localized to certain areas of the body. So let's talk a little bit about non-allergic rhinitis, just to sort of acknowledge it as well. We have idiopathic. This is also known as vasomotor, and we can, sort of break that word down to think of the fact that it is sort of caused by our, motor system. It has to do with, vasodilative properties as well. So this is sort of, idiopathic in general just means that something is sort of responding to non-specific or unknown triggers. We also have NAIRS, which is non-allergic with eosinophilia, or non-allergic allergic rhinitis with eosinophilia. And this is where we see that it's really the eosinophils, the infiltrate in the nasal area that's causing all of these symptoms despite negative allergy tests. We have atrophic or atrophy in nature. This is caused, or characterized, I should say, by nasal crusting, really bad smelling discharge, and sort of nasal deformities. This is where your allergic rhinitis is really combined with a lot of muscle breakdown and tissue breakdown in that area as well. And finally, I want to bring up hormonal rhinitis. This is really interesting because this has a pretty big coincidence with pregnancy. So around a third of pregnant women will experience just a sort of random 6 weeks of rhinitis symptoms, but then these symptoms resolve within 2 weeks of delivering the baby. So there's sort of a suspected hormonal basis here that is related to estrogen and progesterone changes during pregnancy, but this is less is known about that, but I did want to bring it up because I thought it was interesting. So let's just talk a little bit about these symptoms at large. So I won't spend too much time here because I'm sure we all know what it's like to have some sort of seasonal allergy. It's very common. But of course, nasal congestion, sneezing, rhinorrhea, which is a runny nose, and then itching, which is pruritus in the nasal or ocular areas. But the reason I have this slide is because we can think of sort of patterns and triggers that will help us create a diagnosis. So for example, rhinitis is the most common in the morning, and this is partially due to circadian fluctuations in inflammation, such as through cortisol and melatonin fluctuations. Seasonal correlations obviously are going to suggest an allergic or allergen trigger or allergic rhinitis. But let's talk a little bit more about sort of these patterns we might look for. So in a physical examination, if you see asymmetrical nostrils, this is often going to be suggestive of allergic rhinitis or any sort of rhinitis because children especially are going to be pushing their nose sort of off the center or pushing their nose upwards to sort of scratch it or release some of that irritation, and over time that can result in asymmetrical nostrils. So that would be sort of a chronic suggestion. Clear suggestions tend to indicate chronic rhinitis, whereas colored suggestions will be more suggestive of chronic rhinosinusitis. So that's where we start to get the sinuses really involved as well. There's this sort of technology called rhinoscopy that we can use to visualize these nasal structures. And you can see the images here. We're looking for sort of polyps, septal deviations, and things like that. There's also laboratory testing. So as I said, we really look for IgE blood tests as sort of one of the main confirmatory values to tell us that it's allergic in nature. But we can also use nasal cytology. So as I said, there is, allergic and non-allergic rhinitis, and eosinophils are really playing a big part there in differentiating those two. So nasal cytology can look at the sort of cell composition and tell us if it's really eosinophils that are causing it, or whatnot. Typically, when we see a lot of nasal eosinophilia, that's going to be, very predictive for telling us whether or not the patient has allergic rhinitis or not. So here, let's go over the general mechanism. So it is very similar to a lot of allergic inflammation that we covered in previous lectures. So all of the type 2 cytokines, all of those mast cell mediators are going to be playing a role here. But what I want to point out is this idea of the sort of nasal mucosa, which is a tissue layer in the nose, and when it's really overactive, it's going to cause sort of an excess of all of our sort of normal symptoms. So whereas you might have some residual fluid in your nose, well, when the nasal mucosa is really overactive, you're going to get rhinorrhea or a runny nose, and this goes for all of these symptoms here. So let's talk a little bit about some of these symptoms in specific. In sort of isolated contexts. So sneezing is going to be really driven by histamine and cysteinyl leukotrienes, and these are going to act on, unsurprisingly, histamine 1 receptors and cysteinyl leukotriene receptor 1s, and these are going to be present on the nerve ending. So again, I want to bring up this fact that it's really the nerves and the chemical systems that are going to be acting together. Now, if you're wondering how non-allergic rhinitis is going to result in these symptoms, well, it doesn't act on histamine receptors, obviously, but it's going to act on these transient receptor potentials, TRPV1, for example, which responds to sort of environmental stimuli such as dry air or low pH and acidic compounds you might find in the workplace. Let's talk a little bit about nasal congestion and rhinorrhea. So this results from, again, overactivation of the nasal glandular apparatus, which includes goblet cells, but these are responsible for making mucus, which we do need to sort of capture, it's part of our immune defenses. But really, their overactivity is driven by histamine, bradykinin, and plasmid leakage. And really, the sort of defining feature of nasal congestion and runny nose is just increased blood flow, right? We're going to bring all of those inflammatory mediators to our goblet cells. So this is really interesting. This is how nasal decongestants work. So oxymetazoline, for example, is a really common one. And it literally works by just being a vasoconstrictor. It reduces blood flow to the nasal mucosa, and in doing so, this causes less of these mediators to get to your nose, less swelling, and that's sort of how it works. It's a very simple mechanism. So as far as the treatment plan goes, it's sort of going to be based on the severity and duration, but the first step in pretty much all allergic conditions is going to be avoidance. So we just want to find out what your trigger is and avoid it. But obviously a lot of times that's just unavoidable, right? So how do you avoid pollen during the springtime and summertime? It's really difficult because it's everywhere. So that's why a lot of times patients will just be on pharmacotherapy. So for most people, this sort of first level is going to be more than enough. Just taking an antihistamine every day is going to be pretty sufficient. But the thing with antihistamines is that they don't really affect congestion. They only affect things like pruritus. So that's why people would need decongestants like oxymetazoline. So really, using these first two together could be a pretty common treatment regimen. But if those aren't enough, then we might move to steroids. So intranasal steroids like fluticasone, for example, are going to be a pretty potent treatment because these not only help with the inflammation, but they're also going to lower the count of those inflammatory cells. They're going to lower the count of those inflammatory mediators as well. And if those don't work, then people might be sort of on systemic steroids, which are going to have a lot of more adverse effects because they're not as targeted towards the nasal mucosa. And these are really used in the cases where local congestion makes it impossible for intranasal steroids to sort of properly disperse. And the final thing I want to talk about is allergen immunotherapy. So this is a very expensive but very effective treatment for allergic rhinitis, and this is, again, something you would consider if a lot of the sort of traditional treatment regimens aren't working. But this is when you are going to be sort of gradually exposing your immune system to these allergens over many, many months, even years, and this is going to lead to arguably the most desirable effect, which is continued tolerance. So all of those medications I talked about before are not going to give you long-term tolerance, but allergen immunotherapy will. And it also is going to sort of decrease the amount of mast cells and basophils and eosinophils you have in your body long-term. It's going to suppress Th2 sort of immunity by causing them to or downregulating them through anergic processes. And sort of the mechanism is that it's also going to create these blocking IgG antibodies, which are able to inhibit IgE-dependent activation. So this is really interesting. This is sort of a more of a novel therapy coming out in the last few years, but really exciting to think about as a therapy once it gets much, much cheaper. And that is it for my sort of crash course on allergic rhinitis. I hope you learned something.